if you got injured in the field in the Korean or Vietnam War, you had a higher chance of survival than if you got injured outside the hospital in the United States of America. And we need to change that.
Do you want clinicians taking care of patients, or do you want to move the patient? It's a fundamental question we've got to ask as communities.
That's a good question, Doc.
During Trump 1, we successfully enrolled my dog as a durable medical equipment company.
Really? In 2026, people are still using fax machines.
Yes.
Transparency requires the courage to look yourself in the mirror and realize that you're not all good.
2 years. They went from you may not use it to we have an AI major now.
If we don't use it, we are choosing to be ignorant. I thought, what a beautiful statement.
So one of the biggest priorities for me coming back, this is my third tour at CMS, so I'm a glutton for punishment, apparently. But when Dr. Oz called to give me the pitch to come back, one of the things that I made him promise was that if I came back, he would let me go big on the fraud, waste, and abuse issues. Because I felt like there was a lot that I wasn't able to get done, both with Senator Hatch's office and then when I was with Seema Verma working for her, that was undone. We just didn't get it done for a variety of reasons. And the fact is, the world has changed dramatically because of ChatGPT and things like that. The tools, the resources, they're just, it's game changing. And so Oz said, if you come back, I will let you we'll make it a priority and we'll go big. So we started out that way. So when he came on board last year in April, we immediately started, we had kicked off a fraud war room focusing on Medicare claims data. And what we did was we put a bunch of analysts and a bunch of law enforcement people all in a virtual room, if you will, and had them analyzing claims data in real time before it got paid. So we were, instead of paying and chasing, which has been the old way of doing it, we were actually doing prevent and detect. So we'd figure out like that, there was a lab that was billing at 6 times the normal rate in Chicago, or that we had this ever-growing number of hospices in Los Angeles, or many other different things. And then what we started to do was take aggressive action against those, not after the payment, but before the payment. And as a result, since we launched it March 31st of last year until yesterday, we've stopped over $2.5 billion from going out the door. And we only look at like 5 to 7 providers a week. It's a very small number because it's very time intensive to do this, but these are the worst actors. And what I love is we're using artificial intelligence, machine learning, new tools to do that. And that's where the chili cook-off that you mentioned came into play. What was happening was a lot of people have a lot of ideas and a lot of people have new approaches to doing this. And every single person who came in to want to meet with me said, I can save you $2 billion. And I was like, well, that's great. But none of them could prove that they could save me $2 billion. And so what we decided to do was, rather than me meeting with hundreds of these people ad nauseum, we decided to put the money where their mouth was, so to speak, and have a competition. And so we did. We had over 200 people participate. We ended up with the top 10. And of those, 5 of them are working with us on various pilot projects that are ways, new, different approaches to do this. And that's what we wanted to do. So with the war room, what we were seeing was there were problems that we found where we didn't have the regulatory authority or the statutory authority to be able to take care of them or to address them. One of our biggest challenges is Medicare is an any willing provider, payer. That means that it was set up so that literally anyone can get in. You mentioned my dog earlier. During Trump 1, we successfully enrolled my dog as a durable medical equipment company.
Really?
And then as a result of that, we made additional regulations to make it harder so you couldn't do that. But we were able, using my home address, banking information, and everything else, to enroll my dog as a DME supplier. And so it's something where, it's kind of, we wanted to make it so that there was a much higher barrier to entry for people to do that. Because for hospice, DME, home health, it's not as high as it probably could or should be. We have people who have built successful businesses. Chris Klomp, who built Collective Medical and ran a very successful, huge conglomerate sort of vertical structure thing, and has been on several boards and is a real tech entrepreneur. We have Dan Brillman, who started Unite Us, which was a services delivery type of company that has done amazing things for coordinating, all the Medicaid services that people need. So we had some people who came in from that outside perspective. I obviously have not been on the outside. I've been a career government person, but I really love the fact that Oz wanted all of us to think more entrepreneurially. You'll see some of the recent, there was a bust here in LA about a month or so ago that Dr. Oz was, and many of you may have seen his cop style video of that.
I did.
But he was actually there when they took down some people. And what happened was, some of the physicians associated with that had as many as 30,000 patients that they were allegedly referring for. Now, in some cases, the physicians claim they didn't know their number was being used, and obviously that's for the courts and law enforcement to figure out. But in other cases, we were able to show that there really was. They were associated with dozens of home health entities and just signing off on the billings and letting their number be used. So there is a strong responsibility of the physician community to sort of self-police, I think, to a certain extent. But there's also a lot of this is organized crime, and it's organized groups who are doing this. They buy and sell these companies. They buy and sell the beneficiary numbers, and then as a result, they pay money, kickbacks, and other things to these doctors in exchange for their number. Because think about it, one of the things that Dr. Oz likes to talk about all the time is that there are twice as many durable medical equipment suppliers in Southern Florida than there are McDonald's.
Listen to this stat's going to blow your mind. There are 20 times more durable medical equipment providers in South Florida than McDonald's. You need 20 times more wheelchairs than burgers. It's just bizarre.
True fact. There are actually 4 times as many hospices in LA County as there are Starbucks. So, okay, one would argue maybe you don't need that kind of competition, but for durable medical equipment, competitive bidding will make it so that there's a lot less, but hopefully it will allow for better pricing and less abuse and waste on those types of things.
We had the ability to link into some medical records. We did it by paper and faxes.
Paper and faxes,
yes.
And that was not very long ago.
Well, yes. Sadly, that was when I started in the late 80s and 90s, and I still have customers today that come in the door that are sending faxes today.
But we're 20 years in and still talking about this, and you still have people faxing. Mm-hmm. I'm intrigued to know from that piece, because you're like today. In 2026, people are still using fax machines.
Yes.
How is that, and why is that continuing to happen?
It still happens in many cases because the technology that is being used by our EMS providers are somewhat siloed still today. They're not integrating. Medical records are a great example of that. There's very little integration as a whole with the healthcare framework. All the rest of healthcare, really in the world, operates off a framework with the back end of HL7, and then that integration through health information exchanges. Besides the regional state ones, there's some national ones. Epic itself, which is one of the largest EMRs in hospitals, is actually their own healthcare exchange with the volume that they have and what they do. Pre-hospital healthcare, to this point, from a clinical standpoint, there are integrations from our individual silos into that EMR system, that HIE. But right now, it's still largely just a small data dump of certain select items, certain clinical items. In many cases, are still attached as an image or as a PDF with a header for that patient. That's a stark difference. When the patient walked into me in the ER in the 90s, and I put some basic information in our system then, I knew everything about that patient. I knew what medications I should be careful of because of the medications they're on. I knew what their medical history was, and this could be leading towards their prior history of myocardial infarction they had 6 years ago, things like that. Whereas today, a paramedic walks up and may have a name of a patient, may even know the information from a patient, may have a conscious, alert, and oriented patient that can share with them, but still doesn't really have their medical record, doesn't know immediately what medications they need to be considering using on that patient that could be a danger because of the newest medication their family doctor put them on. So that's still fragmented today, and that's still having systems that are faxing records into hospitals. I have hospital customers that I work with that even though they're a hospital, their hospital-owned ambulance system is using a medical record that's separate, not integrated with them, and they're using 3 to 4 to 5 FTE positions, employees, manually keying in the pre-hospital care report into the Epic system so they can bill. So that even today, there's still that fragmentation when they actually own their own ambulance service and operate that provider. I believe it's a bridge product. I don't believe we should all stay where we're at with our current technologies and softwares. I believe that TechScape has to change and modernize so that we can have that true interoperability that it's a buzzword for years. Before we had AI, the buzzword was interoperability. Every conference you went to, every session was about interoperability. The last 2 years, every session talks about AI. We're moving, hopefully not from one buzzword to another, but actually truly eliminating the fragmented service layer, those data silos that we have. AI can help us do that quickly and efficiently. AI can help our clinical caregivers give better care and do backup for them on decision making, looking at all the possible contraindications of a medication or a treatment or something they're going to do. I believe AI used in that model is very beneficial to healthcare and very beneficial to pre-hospital healthcare. But I've seen a growing gap between that executive level and the operations level of the organizations. I've seen an exodus over the last decade where you're really strong young employees that become obviously interested in leadership or have that ability to move into leadership. They're jumping out of EMS and they're not staying there as a career. I think we've lost the ability to craft the career focus of what pre-hospital care is for the generation that is coming in now or that's been in for 5 years or 10 years. And my concern is when these executives age out or decide that they're going to take more time with their families outside of EMS, is that strong person below them that shares their vision, that understands their vision and will keep driving the provider, the paramedics, the crews, the staff towards that goal of taking care of the patient and also being a successful business. That concerns me as I spend more and more time with executives and looking for who's with them and then working with companies. That gap concerns me at night about pre-hospital.
Fred, thanks for bringing that up because that's important. And I think we're seeing a lot more focus on leadership. We can have all the tools. We can have the data. We can have the technology. We can have the doctors and the physicians. But if we don't have the leaders because they're burned out and saying this just isn't worth it to us anymore, we cannot take care of the patients.
Yeah, I have a story to share too about my mother being a victim of surprise billing. And she gave me permission to share the story with you today. So she has a defibrillator implanted, and she was in a pretty well-known health system up in central Wisconsin. And with the defibrillator, they read the results of it on a quarterly basis, and then they bill you for that reading. And it's pretty seamless. We never really received any information or had to pay any cost sharing associated with it, so we didn't even really know what was happening. Then my mother switched her Medicare Advantage plan, and she got into a different healthcare system in the Milwaukee area. And we didn't know, but her old system was continuing to read her defibrillator information and continuing to bill on her behalf. When they found out that she was no longer with the old Medicare Advantage plan, they charged her an out-of-network balanced bill for those services. And it was a surprise to us because we didn't know that we were even being billed for it. They had also sent it to collection before we knew that she was being billed for it because there was a change of address for her as well, and we received it late, so we weren't even able to pay for it if that was an option. So it's an example of my mother, who in the Medicare program was fully insured and fully covered, was sent a surprise bill from a former provider of hers for a service we didn't even know that she was having done on her behalf.
And so tell me how Lisa is using this. How are healthcare economists using AI and some of the work that you're doing currently in your current capacities?
So I'll give you two examples. One as a teacher and then one as a researcher. So as a teacher, I taught an undergraduate policy course to econ students this past semester, and I strongly encourage them to use AI for everything that we did, which is a little bit unique because they get a mixed perspective from their instructors. Some instructors prohibit it, and some instructors are like me, where I say, use it, fully embrace it. So I encourage my students to go into the One Big Beautiful Bill, selectively pull policies, and then submit and upload the policy into ChatGPT and get a plain English reading of the legislative text of what actually is going on in that policy. And I said, you should do this every single time. And you should have it summarized because this is written in legalese. It's written in a way by lots of lawyers with very specialized skills. It isn't really meant for the public to necessarily pick it up and be able to generalize it and internalize it from a read of it. But that's exactly what you should be using AI for. So that's how I use it with my students. I'll also say I asked my students just last week, because it was our last lecture, I always ask them to sort of reflect on what they learned over the course of the semester. And one of my students, I'm so happy to kind of repeat what he said his experience in using AI and what it can do makes him think that ignorance is a choice. Now that we have the capability that we have with AI, if we don't use it, we are choosing to be ignorant. I thought, what a beautiful statement. Because to a large extent, I agree with it. Yeah. So I can tell you a little bit of how I'm using it from a research perspective as well. I rely and I use a lot of government data to analyze the policies that I've put in place and determine their impact. The government data isn't in a user-friendly capacity at all. So there's a lot of cleaning that you have to do. Prior to the current status of AI, I was paying hourly rates to my undergraduate students to clean the data for me before it was even ready for me to run in a regression. Now I can just upload it, put it into AI. I can have it spec'd exactly how I want it cleaned, and then I can pick up that data and run it in a regression. I'm one of those economists who now think that you should be using AI as a research assistant, first and foremost. I still don't feel 100% comfortable having it actually run the regression because there's a lot of decisions and a lot of things you need to think through as you design it and think about how to do it yourself. But it can easily do the work I formerly paid an undergrad research assistant an entire year for in 24 to 48 hours. It's amazing how quickly it can do basic functions like clean data so then I can use it for what I need it for.
So that to me is fundamentally what's at stake here in terms of the modernization opportunity. And we are at the table. The entire industry is at the table. And it's an opportunity for us to lean in. You know, if there's anything that keeps me up at night, it's that we're not going to move fast enough as an industry. We're not going to lean in far enough to the opportunity we have. And we've seen that before. We've had other opportunities to take advantage of a demonstration program or to try something new. And we were maybe a little slow out of the gate, a little flat-footed. Maybe there were some confounding factors, but not this time. The opportunity for us is too great. Our patients, our communities are counting on us. And quite frankly, the data is suggesting that there is so much value created by EMS that's gone unmeasured, it's gone unrecognized, it's gone unconnected. And so that's really what we're focused on. AI is a big part of that equation, how we can start to move into predictive and anticipatory models, how we can understand the populations we're serving, all sorts of opportunities to then rethink reimbursement that actually aligns with sustaining that type of care, both in urban locations as well as in rural. But it's about bringing folks closer together. It's about integrating EMS into healthcare. It's about being able to measure and quantify that so that, sure, we're going to drive down cost, we're going to drive down waste and abuse, certainly fraud, but it's greater than that. Modernization isn't just about reducing waste of all flavors. It's about improving outcomes because that's what we all get up every day focused on. And a big piece of that is going to be how we sustain this.
Let me ask you one question. You made a statement here that said, if we're not afraid of transparency, why do you think, because this has been discussed a lot, and tell me how AI brings that in. Of course, there's a lot of conversations going on around AI right now, And we had a lot of conversations here as well. But why do you think people are afraid of transparency?
Well, transparency requires the courage to look yourself in the mirror and realize that you're not all good. You're not perfect. There's opportunities to improve.
I had to look in the mirror myself and say, maybe you've got something wrong. Is there something that you should be doing different if you're frustrated with continuously talking the same points over and nobody seems to be listening? There seems to be a common denominator. And I think our industry needs to realize that. It's maybe what you just said. Look in the mirror, understand what it is, and what do we need to do to change the system, because the data is showing that we have a lot more value to give outside of just transporting patients that can really impact the system. And we need to seize the opportunity while we can. And that's why I believe doctors like you need to be leading the charge. Dr. Moy, Dr. Cozy, there's so many other doctors, I don't even start to name them. We're just whatever, getting on the piece. But I'm bought into it. Like, I'm 100% into it, and I'm going to use as much as I can with whatever reach that I have to be able to bring that to the forefront with individuals such as yourself, Dr. Beck, that's doing. So keep doing what you're doing. We appreciate it. Keep leading. You lead with you lead quietly, but you lead. And we're paying attention. We're noticing. I know I personally am. I may not like everything that you're doing, and that's okay. You're not going to like everything that I'm doing. But it's important to have the dialogues and to sit and talk. And together, our industry, I believe, can move and transform. But it is going to require looking in the mirror and making some uncomfortable change, and have the courage to do it through the process as well.
We have to start with the foundation. If you got injured in the field in the Korean or Vietnam War, you had a higher chance of survival than if you got injured outside the hospital in the United States of America. And we need to change that. And it was a phenomenal movement by our federal government to say, yes, we are going to serve our citizens and bring them to the hospital. And so that's why EMS is under the Department of Transportation. And it is at that point that I believe we've defined and we've answered the question: healthcare equity and literacy and access to healthcare is a right. We said every American citizen, anybody who's within our borders is allowed to get healthcare. We will transport you to the hospital. That's been answered as far as that whole action has been taken there, right? But what happened there is EMS evolved into not only you call, we haul, that's all. EMS evolved into a healthcare clinician who can treat, diagnose, or suspect certain pathologies and improve outcomes for our patients down the field. And so this may be radical. I know a lot of EMS clinicians have been screaming this at the top of the hill, but we need to get EMS out of the Department of Transportation and into the Health and Human Services sector of our federal government, right? We need that action to recognize our EMS clinicians as healthcare clinicians. And then we can have a Department of Transportation Advisory Committee, as opposed to what we have right now. We have the Department of Transportation owning EMS, and you have the NEMSAC, National EMS Advisory Committee, providing some healthcare information to the Department of Transportation. I think it should be flip-flop.
So you'd invert it?
I'd invert it. I'd put EMS under the Health and Human Services.
Okay.
And yes, transportation is a part of EMS, but that isn't the only thing that EMS does. EMS is a healthcare entity that provides healthcare for our patients, right? That is probably, if we can do that major pivot, that would be a huge change in how EMS practices medicine. And not only that, it will financially support what EMS can do in the field, which is what I've alluded to in the future. So.
One thing that keeps Dr. Moy up at night.
My kids. No. I would say, Hope, I was really thinking about a question like this about the future, especially with my impending presidency coming up. And I get this feeling of butterflies in my stomach, right? And I'm an endurance athlete. I do a lot of triathlons. And it's the same sort of feeling I have when I'm training for a race, when I start a race. The goal is to get to the finish line. But that triathlon, that half Ironman, 70.3 miles, it's a long way, right? So you have to have that ability to see what's in front of you, but also see far ahead of you. And so what keeps me up is really the hope that we will get through this really rough patch we are in healthcare today, be it healthcare finance, be it the moral injury of what we're dealing with as a result of healthcare finance and what's going on in this country. But I'm encouraged because I have a lot of colleagues who are passionate about their patients, passionate about what's doing best for them. And I know that the only way you can lose the Ironman race is it's a death by a million cuts if you just stop running. The goal is to just keep on going one step at a time. And the goal is to get those butterflies that I'm feeling that are keeping me up at night and to get those butterflies to fly in formation. That's the goal.
I love it.
If I've got a guy that comes in with overalls, he's automatically sick. It's almost like the sixth vital sign. So it's a language that folks are using in this environment that is completely different than urban. And we didn't have blood donation. We didn't have blood delivery in our state at all, except for the helicopter. So if you needed blood, you got an $85,000 bill. And you only got it 40% of the time when they were flying. 60% of the time, they don't come in our state for a lot of different reasons. So now we have people on the side of the road that need blood, and I could use whole blood, which is awesome in the Mecca centers across the country. But guess what? There's not a hospital in Mississippi besides one surgeon that uses whole blood in the hospital. So now I'm going to waste the whole blood. So I can't waste blood in rural Mississippi. I've got to use it or give it back. It's such a valuable resource. So we've developed a rural blood program that's given 18 months. We've given over 60 patients blood transfusions, and we've only wasted one unit. One. And in the meantime, we've got at least 500 new donations of blood into the system to help with our other needs in blood delivery. That's not an urban concept, right? They have the ability. They have the gun and knife club. But what's also been interesting, I'm not academic anymore, so I can't publish this stuff. But we've yet to have a physiologic normal, abnormal laboratory value on arrival with a patient we've given blood. Less ICU stays, less transfers, and it's not just trauma. It's GI bleed, postpartum hemorrhage, it's all those things that are out there. And that's coming from a rural perspective. How do I do it on the cheap, on the cost? And guess what, Asbel? No one's paying for it. Not the first payer is paying for it. And we have a lot of cow versus people in those events. And we realize that they have a very interesting bacterial infection when they break their bones. So we went and cultured the dirt. We found there's a very specific bacteria in the dirt. So now when we have an agriculture injury, we're adding in 2 grams of a very inexpensive antibiotic, $4, because the evidence says you need to have a washout in 6 hours. So what we did, Asbel, was we took an IV bag with some betadine, and we did, and excuse my French, a redneck washout. And we're going to do it with every patient now that has open fracture in rural America. Every patient has agricultural injury in rural America. And what we found is the morbidity of those patients, not one has had an infection from post-op complications. Man. Now, is that coincidence? And the research people out there are probably flipping their heads now. I'm not academic. I don't have a force of 500 people to look at this stuff. I'm telling you real life numbers. It's there. And the stockyards believe in it so much, they're my number one donor of the blood program. What do you want as a community? Do you want clinicians taking care of patients, or do you want to move the patient? It's a fundamental question we've got to ask as communities.
That's a good question, Doc.
Do we want to move the patient, or do we want to take care of the patient? Name me another healthcare system that will always move someone to the highest level of cost and don't report quality. It's not out there. We're the lone survivor. And until we start talking about that concept, we will continue to be paying for diesel or jet fuel. Great example, dialysis patients. Literally one change that could be made with our friends in government would be allow local hospitals to transfer a dialysis patient to their existing dialysis chair. We can't do it. So now a third of the patients that are in the system in my state, in the transfer system, a third, are only going because they happen to be on dialysis. Not that they need dialysis, they don't need emergent dialysis. They can be cared for locally, but they're being transferred just because they have dialysis.
There was a lawsuit recently where an individual who had been in a criminal lawsuit had been indicted, and in preparation to talk with his lawyer, went online and to ChatGPT to frame his legal argument. And when the prosecutor sought to discover the information used in an open source AI, the lawyer went to move that it was privileged because he was framing his legal arguments and working with his attorney, and he lost the case. And because they said essentially the presence of a third party, in legal terms, presence of a third party destroys privilege, and they said essentially this open source AI was in fact the presence of a third party. Now, had the lawyer instructed the defendant to do it, maybe that would have been a different result. But I think, this is one of those things where, and I consider it every single time I draft an outline or something like that my information's being used to train the artificial intelligence as well. And so you just have to be cognizant of that.
I think it was Grammarly at the time, or something like something,
right. Yep.
Whatever.
Yep.
And then once they OpenAI came out, or ChatGPT is what most people remember. It was like, and I remember people saying, this is scary. We should do this. I don't know if we're ready for this.
Yep.
But they opened it up and in people dove.
Yeah.
And
I was going to say there was an attorney, I think in the state of New York, who got disciplined by the bar for citing a case that actually clearly he'd used one of the open source AIs, and it was a Law and Order case from the television show, right? And so, one of the things we say to folks is it's a good place to start. You need to understand what tool you're using. You need to understand whether that tool is an open or a closed source tool, and then understand how folks in your organization, because if you think they aren't, they 100% are. I know 2 years ago when I went to my daughter's school, there was a no use of AI in the classroom. Now, this year, they have an AI major. Yeah. That's 2 years. They went from you may not use it to we have an AI major now, because they're realizing that it is inevitable, and it's better that you understand how to use it and what the risks are associated with its use, and then use it in a way, because there are many ways in which you can really save a lot of time and a lot of money, but you do have to make sure that the human piece will never be removed. I think there should be disclosures by all. And in fact, we're seeing this again, just like with body-worn cameras. Oftentimes I think the first thing you should do is announce, listen, there is not only audio, but video recording going on. Now, depending upon the state you're in, right, there are one-party or two-party consent states. My state is a two-party consent, or it's actually a knowledge rather than a consent. Presumably you walk away if you don't consent. But in many states, it's a single-party consent, which means, and which I sort of smile at, because usually one party always knows it's being recorded, right? But again, I think it comes down to, and this is, we're preparing a checklist, our firm starting to build some tools around the use of AI, and it's really inventorying your team, all of your team members, to find out where it's being used, right? Because when I'd say to EMS leaders before, hey, I guarantee you your staff are using canned narratives that are recorded on your tablet PCRs, that they're just dropping in. So that's not a good thing.
Right.
And so they'd said, no, there's no way they're doing it.
Oh, yes, they are.
And I'd say, pull in all your tablets. I guarantee you there's 4 or 5 sort of canned, a shortness of breath narrative, a chest pain narrative, whatever. And so this really comes down to having an open and honest conversation. Tell people, listen, we're a judgment-free zone. We just want to know how you're using it. because I will venture to bet probably 90% of people in your average service are using AI in some form or fashion. And like, for example, if they're going to ChatGPT for the purposes of asking, geez, what's the appropriate dosage for a pediatric patient? Again,
or they're using Claude or they're using Perplexity. There's so many AI components out there right now, Scott, that people are using that we need to be. So I love that you're doing that. The firm's getting involved because I think it's going to be ever evolving and it's going to be changing rapidly. And so you have to think about whatever policy you have. These are probably policies that you're going to be updating in frequency. Yeah. You're going to have many versions of it.
This won't be once a year. This will be once a month. You need to revisit the policy.